I'd like to thank Nathan Hutchinson-Jones for giving his time and support to this conference. Nathan is the lead pharmacist for thrombosis and anticoagulation at the Royal United Hospital in Bath. He's worked across hospital and primary care and was involved in the Don't Wait to Anticoagulate project, which looked at optimising anticoagulation therapy for patients with non-valvular AF. In his role at the RUH, he is involved in regular haematology thrombosis clinics and has set up a new cancer-associated thrombosis service, which works as part of a multidisciplinary team supporting primary and secondary clinicians to help optimise anticoagulation services. And really, from this is what came out, of this project. So without further ado from me, I will pass over to you, Nathan, and say thank you very much. Or could I just, add, if you do have any questions, in probably the foot or the top part of your screen, you'll see a Q&A option. If you click on that, you will be able to submit a question, which we'll try to answer this session. Okay.
Great. Thanks so much, Jo. And yeah, big thank you to Jo and the team at Thrombosis UK and thank you very much for asking me really to present at this. So Jo obviously explained a little bit about my background, and I've been in my role now for several years, and just to give a bit of context for those who maybe don't work in the NHS or know the RUH, we're sort of around a 800-bed district general hospital in Bath, which is in sort of a fairly sort of semi-rural area of the southwest of England, but encompasses the city itself of Bath and a lot of sort of surrounding sort of countryside-y type areas. But as Jo said, when I first started, we sort of did a number of things to try and assess what the current problems were when it comes to anticoagulation. And as you can imagine, there were a lot of potential problems. But one of the things I wanted to talk about today, or the main thing I wanted to talk about, I should say, is a pilot we did over a couple of years, which was where we implemented a standardised anticoagulation review in primary care in the community for patients who were on long-term anticoagulation. And this review was done by myself and one of our anticoagulation nurses, so both based in hospital in secondary care, but going out into primary care, into the community, and working with patients and GPs and other primary care healthcare professionals to optimize anticoagulation. And essentially, the aim of it was to try and prevent some of the harm events which we were seeing due to anticoagulation, which I'll come on to in a moment. So, and as Jo said, any questions, then obviously feel free to put some on the Q&A. Or I've got my email on here as well, and my Twitter handle as well. So, I'm happy to be contacted for advice or just, questions. And all the information that I'm going to give today. So we have published this in the Journal of Primary Healthcare Research and Development, which so you can read more about the project in more depth at another time. So I've kind of going to keep it quite fairly simple if I can. And as I said, if you want to go away and look more about it, then you can afterwards. So I suppose with any high-risk medicine, particularly anticoagulation, the aim is always not to do harm to our patients, but unfortunately, certainly with anticoagulants and many other high-risk medicines, we sometimes do harm our patients. So, I suppose this highlights the importance of managing these patients appropriately and trying to minimize that risk of harm as much as we can, which can be very difficult, particularly now where we're in an age where we have a number of different anticoagulants, not just the traditional anticoagulant of choice, Warfarin. We also have all of the direct oral anticoagulants, or DOACs, and I usually call them DOACs rather than NOACs, but you might hear either. So, whereas that has been advantageous in terms of giving us more choice and more treatment options, it does mean that with all the different dosing and all the other different parameters we need to think of with each different drug, managing these patients has become more complex, and certainly there has been a big push to anticoagulate more patients, particularly from an AF point of view, where we're anticoagulating more and more patients now. And certainly I think from a VT perspective in regards to unprovoked DVT-OP in men, then most of those now will continue long-term anticoagulation, and so will a lot of women as well. So we are having a lot of patients on these high-risk drugs, which when they go wrong can be very detrimental to the patient's health and also to the health economy as well. So going back a little bit, so when I first started at the RUH, we decided to do a scoping audit to try and assess where we were with harm events in regards to what we were seeing coming through the front door at the RUH. And what we found was a little bit worrying. And this scoping audit was done over a 12-month period, so through 2016, and was carried out retrospectively. Some of the main findings I've put on this screen, and I think they're quite scary actually when you look at it like that. And so overall, the anticoagulation-related harm events resulted in around 1,500 hospital bed days, with a mean length of stay of 29 days and a mortality rate of 20% within 4 weeks of admission. And I think, as I said, that's quite scary. And the data we collected, so we primarily looked at patients who had been admitted with known atrial fibrillation, and had either been admitted not on an anticoagulant and subsequently suffered an ischemic stroke, or patients who were anticoagulated already with known AF, but still ended up being admitted to hospital either with an ischemic stroke or significant bleed. And the other group of patients that we looked at were patients anticoagulated with warfarin for any indication who had a high INR on admission, and where it was felt that that high INR was felt to contribute to their admission. And we purely looked at those patients. So we didn't look at patients who were on long-term DOACs, for example, for other reasons, say, for example, treatment and prevention of VT. And I think, so they makes this data even more scary because it's probably an underestimation of the true level of harm events. And to give you a bit more in-depth detail about some of the numbers. So when we look at patients who were admitted with known atrial fibrillation and who were anticoagulated but still suffered an ischemic stroke, we had 35% of the number of patients, so 47 patients were essentially admitted with an ischemic stroke despite being anticoagulated. And I know that you're never going to get that number to zero regardless, but certainly a number of those patients were on an incorrect dose of a DOAC. They weren't taking it. If it was rivaroxaban, they weren't taking it with food. If they were on warfarin, they had a subtherapeutic INR. So there were lots of reasons in there which, if they had been addressed sooner, then they might have prevented some of those events. And we also had a high number of patients, 54 patients as well, who were admitted with known atrial fibrillation. So it was established on their record, but weren't anticoagulated, and they subsequently admitted with a stroke. And I think that is difficult as well, as some of those patients will have inevitably had quite a high bleeding risk. And I think sometimes with anticoagulating patients, particularly in AF, we do it based on risk, and you can say that somebody might have a higher risk of bleeding and justify not anticoagulating them, but there is still a risk of stroke there. So some of those patients probably were not anticoagulated for very good, appropriate reasons. But I think what we were trying to highlight is that in some cases, there wasn't clear documentation of why they hadn't been anticoagulated. And certainly in some cases, they hadn't been reassessed for a number of years. So, where some patients might have had a reason for not being anticoagulated at one point, or may have shown, that they might have said they didn't want to be anticoagulated. But then that had been so long ago that nobody had readdressed that. And also it's very difficult to know what information those patients have been given as well. So there were lots of problems basically. So so this was the basis really for us thinking what we could do as a secondary care hospital team to try and support primary care where all these patients are. And just to give you a bit more context, I know sort of commissioning of anticoagulant services, whether that be DOACs or warfarin monitoring, varies in different places around the country and internationally. But locally then, warfarin monitoring is mostly provided by the GP practices. with some GP practices subcontracting that INR monitoring to the anticoagulation team at the hospital. So there's a little bit of variation there. And in terms of the DOACs, then prescribing is done, long-term prescribing is done by GPs, but there's no sort of standardized way of reviewing and managing those patients really long-term. So it was from all this data essentially that we decided that something we could do perhaps to try and help was to implement a new service whereby a specialist multidisciplinary team, so that being us, so myself as a specialist pharmacist, we had a specialist nurse and consultant hematologist, to essentially go into primary care, work with GPs, work with primary healthcare professionals and patients, and essentially try and sort of implement a standardized review process, which could be done on, say, an annual basis to constantly reassess and sort of monitor these patients with the aim of optimizing their anticoagulant treatment and reducing the risk of harm. So this was for patients on any form of oral anticoagulant. So for us, that meant either patients on warfarin or on any of the direct oral anticoagulants. And this was for, we decided to do it for any indication. So whether they were being anticoagulated for stroke prevention in AF, or whether they were being anticoagulated for prevention of recurrent VT, for example. So the way we did it, so the first thing was to come up with a structure for how we were going to review the patients. And one of the documents that we used, which was very useful, was a document that was published in 2016 by the London Clinical Network on the ideal anticoagulant service. And it was focused on stroke prevention in AF, but we essentially used it and adapted it to sort of for our own needs, really. And we came up with a structure for reviewing patients on warfarin, and we also came up with a structure for reviewing patients on DOACs. And we did these reviews ideally face-to-face with patients at the GP practice to try and sort of get, review them, I suppose, in the community, closer to their home, as it were. Some patients we did on telephone if needed, and certainly there were some sort of negatives in terms of we weren't able to review all the patients that we would have wanted to, and some patients who were in nursing homes, things like that. So but as I said, for this sort of pilot, as it were, then it gave us enough patients essentially to get some data. So with the warfarin reviews, we looked at indication, assessing and correcting risk factors of bleeding if possible. So one of the main things we focused on there was the co-prescribing of antiplatelets or NSAIDs. And I think it's very difficult with antiplatelets in particular, as one of the things I get asked quite a lot by healthcare professionals in primary care is whether patients need to be on an antiplatelet in addition to an anticoagulant. And it's very hard because sometimes these patients have been on it for quite a long time, and it's not very clear whether they should be stopping it, what the risk is of bleeding. So it is very tricky. And I think this is one of the things that I think particularly having a specialist team carrying out these reviews and supporting primary healthcare professionals was being able to link in with other specialists in secondary care, such as the cardiology team and the stroke team, to ascertain whether these things were appropriate. Because I think that decision making in primary care can be difficult sometimes, a lot of the time because you don't have all the information to make that decision. The other thing we looked at, which was quite important, was time in therapeutic range. So looking for a target of over 65%, discussing alternative anticoagulation strategies with patients. So this was particularly important with the warfarin reviews. So a lot of it was assessing patients to see if they would be better anticoagulated with a DOAC, discussing the different DOACs with the patient. And we decided to not give preference over any one DOAC, but sort of offer patients a choice of all the DOACs. And there may have been certain characteristics or certain patients that may have meant we were more keen for one over the other, but we tried to make it a joint discussion with the patient and tried to make sure that they were aware of all the different options and what the rationale and what the necessary things are with each one, because they're all slightly different. Another thing I think which was quite important, and particularly from a patient perspective, sort of went down very well, was about patient understanding for why they were anticoagulated. And certainly there were some patients who really didn't understand at all why they were taking these drugs, which obviously has then consequences for things like adherence, which was another aspect of the review. And another thing we talked about with patients was possible side effects as well. So in terms of DOAC review structure, some of these points were similar to the Warfarin review, particularly things like indication, adherence, patient understanding, and possible side effects. However, there were also some other things as well. So particularly focusing on appropriate dose. So I think one of the problems, certainly locally where we are, is one of the problems we've identified is that with the dosing criteria being different for, particularly with the DOACs, with different DOACs and with different indications, then and certainly a lot of the parameters. So if it give you one example, so apixaban, for example, in AF, if we think of things like age, weight, renal function, well, those are all things which tend to vary and change with time. So some of these patients may have been started on a DOAC, correct dose, everything fine, but then, sort of several years later, various things have changed. And as a result, the dose they're on is no longer appropriate. And I think that's the same with certainly, all the DOAC patients, is that, a lot of the time we are starting these patients on a correct dose, correct DOAC and everything. But as time goes on, lots of things change. And even if we've counseled the patient, I think, on when they've started an anticoagulant, if you're talking several years later, then I think it's quite difficult to remember exactly that conversation. So, I think what I'm trying to get at is that, where we carried out this review, the thing we wanted to try and emphasize was the importance of reassessing these patients. And certainly when you compare it to the Warfarin patients, I think it's interesting because one of the things with Warfarin, obviously, is that with the need for INR monitoring, they are having the regular engagement with their GP practice or hospital secondary care team or whoever. And I think that in some ways does mean that they get more input sometimes from us. And, if they need to ask questions, and I certainly think from understanding wise, I think the Warfarin patients probably had a better understanding of their treatment. But I think that was because of the interaction they were having with healthcare professionals. So I think, as we move a lot of patients from Warfarin to the DOACs, and the need for these annual and regular assessments of these patients is very important, as I think the tendency has been that we have moved a lot of patients onto these drugs and started more and more patients on these drugs, and a lot of them unfortunately have probably been forgotten about, and subsequently then we see them several years later with a harm event in hospital because they've not been taking it appropriately, they've been on the wrong dose, etc. And the other thing with the Warfarin patients is because a lot of our straightforward patients now on Warfarin for AF are no longer on Warfarin, they're on the DOAC. It means all the Warfarin patients we tend to be left with, particularly post-COVID, where there's been a massive push that anyone who can take a DOAC should be switched. We're left with all the really complex patients. So you're talking about patients with antiphospholipid syndrome, recurrent VT with higher INR targets, mechanical heart valves. They're all really difficult patients to manage. So, you can see, again, the importance of sort of regular engagement with these patients, really. So, just going to go back one sec. So, in terms of carrying out these reviews, all these reviews were around 25 minutes in length. The initial funding for this project, which I should have mentioned at the start, was through the hospital. We have something called the Innovation Panel, which is essentially a fund that the hospital provides for small projects, basically. So we were very lucky in getting that funding to allow us to carry out this project. So that was really good. And as I said, we did a variety of face-to-face and telephone consultations depending on the patient characteristics. And I mean, we certainly, there were some limitations in the way we carried out the project, but I'll come back to that in a minute. So after carrying out these reviews, some of the key things that we found, so altogether 821 patients were reviewed over that 12-month period, which was a lot of patients, as you can imagine. And out of 172 eligible patients who were prescribed Warfarin, we had just over a quarter who chose to switch to a DOAC. Now, that 27%, I suppose one of the things you might think is, oh, well, why is that number quite low? I mean, it's fairly comparable with other studies. And the one thing I would say with that is that in terms of reasons why patients didn't want to change, they varied. Sometimes it was because they'd already tried a DOAC and had a previous adverse reaction. Sometimes it was because they were very well controlled on their warfarin, and actually, they're fairly well controlled and they enjoyed the contact with the team, etc. So, that was another reason. But another reason, which I thought was quite interesting, was that a lot of patients were open to the idea, but didn't want to make a decision there and then. They wanted to take time to think about it. They wanted to discuss with their family, with their carer, with their GP. And I thought that was interesting, because I think certainly from our perspective, a lot of these patients, had never seen this before. And I think for a lot of patients, they had a GP, for example, that they had known for a long time. And I think there's a lot of level of trust there. So I think that's quite an interesting finding from that as well. So for them, it was quite important that even though, they were grateful for our input, they wanted to have a chat with their GP as well. And what I think is interesting is certainly, even though this wasn't part of the project, that since we did the project, a number of patients who we discussed at the time have subsequently decided to switch to a DOAC further down the line, after they'd had time to think about it, after they'd had time to give read the information we'd given them, and after they'd had a chance to discuss with their regular GP, their practice, whoever they wanted to discuss it with, really. From an average time in therapeutic range, we had an increase from 73 to 75%, which not a massive increase actually, but I think we were probably starting from a fairly high level, actually. The patients all the patients we reviewed, or the average time in therapeutic ranges actually for the patients overall for the practices that were having their INR monitored through the hospital, was already quite high at 73%. So I think that's the reason that that didn't improve much more than that. But certainly I think most people would be happy with an average TTR of 73%. So and this is one of the really key bits of information for me as well, is that out of the 482 patients taking a direct oral anticoagulant, then we found 35 or 7% were on the incorrect dose. And actually, after just notifying the GP of this, we had 91%, so 32 of the 35 patients had their dose amended. So I think that really shows that, nearly all of those patients were on an inappropriate dose and there was no reason for that. It had just been an oversight for whatever reason. So whether or not their weight had changed, or whether or not they were older and they'd been started on the lower dose, say in hospital, but with no reason given. So perhaps just because they were older, or because they were at risk of falls, which is another reason sometimes if using off-label lower dose in older patients. So there were lots of reasons. And there were a couple of patients which we continued on the off-label dose, but they were very specific reasons. I think from memory, I think 2 of them were oncology patients, and they were on a lower dose because of bleeding risk from their cancer, and that was clearly documented from their oncologist in the patient notes. And I can't remember what the other one was, but there were good reasons for all 3 of those. And certainly, I think the other problem with that is some of those patients were on the wrong dose, but some of them had been prescribed that wrong dose by secondary care in hospital. And I think that puts particularly GPs and other healthcare professionals in primary care in a very difficult position, because it's hard to distinguish whether they have been deliberately put on that incorrect dose for a specific reason, or whether it is just an error. So what I would say is that if there is that situation, then don't be afraid to question that. And I mean, certainly, I know things vary depending where you are, but certainly it's one of the queries I get quite a lot as a specialist anticoagulation pharmacist based in hospital from GPs, practice pharmacists, practice nurses about some of these patients. And as I said, sometimes there is a clear reason, but it's not been clearly documented. Majority of the time, it's it doesn't happen loads, but the majority of those cases, it tends to be an error. And certainly there were other patients as well who had been prescribed inadvertently antiplatelets or NSAIDs where actually they weren't appropriate. Certainly with some antiplatelets, the classic was that they've had some kind of cardiology assessment at some point, or intervention, and they've been started on an antiplatelet or dual antiplatelets with an anticoagulant, and then as time has gone on, essentially they should have stopped the antiplatelet, and it's not been done for whatever reason, whether or not it was clearly documented or it's just been missed off for any other reason. So that was quite a sort of a significant thing we found as well. And as I said, there were also quite a lot of patients where actually their understanding, even though we didn't formally assess this, then we certainly found that a lot of patient understanding, particularly with the DOACs, was quite lacking. They really didn't quite understand why they were on these sort of drugs, which is important, particularly when we think of things like adherence, for example. And I will say that most of the patients we found with the DOAC, certainly, then most of them were taking them correctly. However, we did have a couple of patients who, for example, with apixaban, were taking it once daily rather than twice daily. And we also had a couple of patients as well on rivaroxaban who weren't taking it with any kind of food as well, particularly when it comes to the higher doses to ensure good absorption. So, I mean, certainly the feedback from the project was very, very positive. And even though, we hadn't essentially done a formal assessment of the new service, our outcomes would certainly suggest that some kind of annual anticoagulation assessment, which is standardized, and done sort of with patients, then there is a possibility of benefiting them by trying to optimize their anticoagulation therapy. And hence, when at the beginning I was talking about some of these harm events that we were seeing, then the aim would be that we would try and reduce some of those harm events. Though, as I said, we haven't done that assessment, but that would be the hope, essentially. I suppose the other thing is that the important thing, or one of the good things that I think this is an example of, is working between different sectors as well. So, in the community, primary care and secondary care. And I know that certainly internationally that, healthcare provision is different to the NHS, but certainly I think the results of this could be taken as a good example of working between those different sectors, which I'm sure could be used sort of internationally as well. And that, we decided to do the model with the secondary care team carrying out these reviews, but certainly it's not necessarily the way it has to be done. And I think around the country, there are, different ways of doing this. And I think secondary care teams are in a good position, I think, to try and either provide these reviews or actually just to support primary care with carrying out these reviews. So there's no, for example, that could be with training and education, or just support for particularly complex patients. So they can be they can be done very differently. But I think the communication is probably key here. And certainly the regular reassessment and engagement with these patients. And I think it is difficult because obviously, certainly the NHS is under a lot of pressures, and particularly with COVID and things like that. But I mean, sort of going forward in the future, then, there is certainly a lot of harm happening from these drugs that we're using for these patients, which obviously we don't want. So it is in our interest, I think, to try and do more with this. And it is my hope that this pilot and certainly will sort of encourage other people to do similar projects, and actually for it to be able to influence local and national commissioning of services to try and improve things for patients, really. So I hope that's okay. It was I've given quite a, I've not gone into too much depth. If you want to read this paper, then please do. It's free access on the internet. And I put the title of the paper on the screen. It's got a lot more detail than what I've just said. I've given you sort of quite a brief overview, really. So please go and have a look at that. But I wonder whether maybe now would be a good chance just to maybe, if anybody's got any questions at all, or whether Jo has any questions that she wants to ask, then that would be a good time to do it now, maybe.
Thank you, Nathan. That was really interesting. I do have a few questions, actually. Can I also just say for everybody listening, within the Let's Talk Clocks platform, on the In Touch section, this paper is included there as well for really easy access. So you can find it there on the In Touch page. Yeah, while setting this up and obviously then in delivering it, did you include or find that you needed to include training for primary care staff so that it became a collaboration and something that was very sustainable?
Yeah, no, it's a really good point. And I mean, you're absolutely right, because obviously the pilot went very well, but I mean, we essentially did the pilot and then stopped doing it. So, but I mean, yes, you're absolutely right. I think the training side of things is very important. And, from the results of this study, one of the things that we did was to feedback the results from the study to the GP practices who were involved with the pilot, essentially giving them the key messages that we got from the pilot. So, you know, and making them aware of some of the problems. And I think a lot of them were quite shocked actually that you know, the number of patients who were, for example, on the wrong dose, for example, you know, they really weren't aware of it. So we try to do it that way as well, to try and raise awareness with those GP practices that we're involved with. The other thing that we've been doing quite a lot of is working with our local commissioners, so with CCG through the practice pharmacists, to try and do more education and training with them. And since this, they've been doing a number of projects where they've been reviewing patients who are on DOACs, including checking that they're on the correct dose, etc. As you can imagine, it's a massive group of patients now. So, you know, what we found is that with the practice pharmacists, they've been having to concentrate on particularly high-risk patients rather than do them all, because otherwise it's overwhelming with their other work. And certainly, you know, even those reviews are not necessarily in the same depth and level to the one that we carried out, but it is something. So yeah, we've been doing quite a lot of work on that, and I'm hoping as we go forward, you know, we work more and more really with primary care. And sort of, and as I said, you know, with this kind of review, I mean, obviously we decided to carry it out ourselves, but there's no reason they couldn't be done by another healthcare professional. So whether that be a practice nurse who's got an interest, or a pharmacist, a GP, whoever. And I think it's all about, as you say, about training and standardizing that sort of educational side of things, and getting people up to the same standards so that they can provide this information. I suppose one of the limitations will be that in terms of the way we did it, we had plenty of time, we had lots of resources, you know, and obviously in terms of getting that side of things, it's quite difficult, I think.
Okay, thank you. A question has come in saying, well, great talk, and asking, do you have, for your DOAC review, what do you use to review it? Do you use the EGFR or Cockcroft-Gault creatinine clearance to assess renal function? And did you have significant engagement from patients who used intravenous drugs on treatment for VTE?
Oh, that second, that, yeah, right, so I'll come on to that now. So, okay, they're very good questions. And certainly so talking about renal function first, I get asked all the time about renal function. It's like really common. And what I would say is, most of the time you should use Cockcroft and Gault. I mean, certainly I think locally now, then we have built into the prescribing system, I think we have an automatic sort of calculator that you can use to try and help GPs, healthcare professionals in primary care. Because I think one of the problems is that EGFR is reported by the labs. So, you know, it's obviously an extra kind of step, isn't it, having to do that extra bit of work essentially. But certainly all of the studies, all the randomized controlled trials which looked at DOACs all use Cockcroft and Gault in terms of you know, what their parameters are for dose changing. So really we should be using Cockcroft and Gault. And that being said, I mean, you know, I'm talking as if Cockcroft and Gault is the sort of, will give you a much more accurate answer to their renal function. We have to remember that both of these things are estimates, but certainly I think most patients with those, particularly older patients, I would always calculate the Cockcroft and Gault for that calculation. You're absolutely right. You know, younger patients maybe where then, you know, who are a normal sort of weight and BMI, then, you know, EGFR is probably relatively reflective of their renal function, and there's probably not so much need to do a creatinine clearance essentially. The second part, the IV drug users for VT, they're a really difficult group to engage with, and I know that because one of the clinics I do separate to this project and everything is hematology thrombosis clinic, and some of the patients which who have very poor attendance and engagement with are those patients who are IV drug users and have had a VT. And, you know, in terms of showing up for clinics and things like that, it's probably less than half, if that. In this project, we didn't particularly look at that group of patients, but I think that is a really big piece of work that needs to be done. And it's actually probably a really good research project if anyone wants to do it, because I think we really need to work out how we engage better with those patients, because in terms of things like adherence, taking the medication with food, understand it, all those things, I think they're a particular group of patient where that's really difficult to do. And certainly that's been my experience. And they're often particularly prothrombotic and recurrent VTs, really, really hard to engage with. And as I said, we see, you know, certainly from a hospital perspective, I've seen, you know, some of these patients just come back and fall basically. But certainly, you know, there's been times where I have managed to engage with some of these patients. And to give you some examples there, I remember one patient saying, and, you know, they were on apixaban, I think, for recurrent DVT, and you know, they were sort of homeless, and I remember, you know, we switched him to a once daily one, edoxaban, and I think on the rationale that it was less tablets to take, and he could fit them more easily in his backpack. That he, you know, it's things like that that, you know, we talk about with DOACs and the need to sort of discuss all the different options with patients. And I think, you know, that's one example of a good group of patients where actually there may be things that you wouldn't normally think are relevant, but to those patients maybe they are. But yeah, very difficult group of patients. And I'd be really interested if anyone has any knows any good data or research that's been done in that area, actually, because it's certainly an area we've struggled with.
Thank you. Another question's come in saying, to CRCL, there's always discrepancies between using actual and ideal body weight. Which weight should we use?
Oh, that's really hard again, isn't it? Because in terms of, I mean, this is what I would do. So when I use Cockcroft and Galt, I usually use I haven't got shares in this, but it's the MD Calc website that's on the internet. So I find it very useful because it allows you to put in the patient's weight and the height, and then it will actually give you at the bottom their creatinine clearance based on their actual weight. And then if they think that they're overweight or obese, it will give you a range using adjusted and ideal body weight. Now, if you look at that information on there, it will tell you that the evidence for using adjusted or ideal body weight in overweight or obese patients is debatable as to what you should use. But what they give you is it's a range between the two. So I think if you have a patient who's overweight or obese, then actually it probably is worth working out either a ideal working out creatinine clearance based on ideal body weight or a adjusted body weight. And as I said, I can't tell you exactly which one is the correct one to use, but the reason I like MD Calc is because it gives you that range. So sometimes you can make just a call based on what that range is, essentially. So I've kind of copped out a bit of that one, but that's what I do in practice.
We've got time for one more. It's with the edoxaban, which you mentioned earlier in your talk, and relatively normal renal function. Is there a risk that their renal function is too good, so won't achieve therapeutic dosing?
That's a really good question as well. And I know, I think there was a fairly, I mean, in terms of use of edoxaban locally, we're not using loads of it. It's increasing a little bit more, but we mainly use apixaban. But certainly elsewhere across the SCP or in the geographical area, there has been a move to using more edoxaban, and there has been some concern, I think, in patients where I think it's the creatinine clearance is over 90 or over 100. I can't remember what it is, but certainly I think there is a caution there in patients who are anticoagulated for stroke prevention in AF, that actually it may mean that you are getting a reduced efficacy in edoxaban. So I mean, you know, as to whether it's only edoxaban, I think that has that warning. So I think in those cases, I would probably err on the side of caution. And the fact that we have 3 other DOACs and warfarin, I would probably just use an alternative DOAC. That would be my advice.
Nathan, thank you so much. I think we could go on talking about this for a long time, but I'm aware that the time has run over. We've already got messages in saying thank you, that's a great talk and great answers. Just to reassure everybody, this has been recorded, so you will be able to revisit or tell your colleagues to go and visit as well. And the paper that this presentation is based around from Nathan is also available within the Let's Talk Clots platform on the In Touch section, as well as on the internet as well. But for now, thank you so much, Nathan. I really appreciate your support. Thank you.
Thank you. I hope everybody enjoyed it okay as well. And as I said, more detail in the paper. So, and any questions, I'm more than happy to either via Twitter or email. It's no problem. As I said, you know, just send them through if you've got a burning question.
Brilliant. Thank you. Thank you to all the attendees who joined. We had good numbers. And thank you also, I'd like to say, to all the supporters and to the sponsors who have made this platform possible for this week's support of World Thrombosis Day. So thank you very much. Please go and visit the exhibition and have a look. There's a wide range of stands there that with lots of information and interesting films on too. Thank you so much. Okay, bye-bye.